One other really important factor when I'm deciding that first line of therapy for patients is really the treatment mechanism. Because now, for the first time in kidney cancer in a long time, we have a choice. We have a choice between VEGF TKIs, and there are several, but we also have a choice between immunotherapy. And historically, that might have been high-dose IL-2 that we might consider for just a small subset of patients. But now, with the advent of checkpoint inhibitors in particular, with opportunities with nivolumab and ipilimumab, and maybe even combinations of VEGF and checkpoints in the future, we're going to have to decide now how to start patients off and which arm of these different modalities we want to start with. And for me, I think this is going to be kind of an evolution in progress. I have a lot of experience treating patients with VEGF TKIs, and I know how to do that. I know what doses patients can tolerate and what are the signs and symptoms to look for to say we need to take a break or we need to lower the dose, or how to get that. And what I like about those therapies is, for the most part, those toxicities are quickly reversible. So if we run into a trouble with a diarrhea, with a nausea, or hand, foot, or hypertension, I know that I can hold those medicines, and within days to a week or two, they're going to resolve. The tricky thing with IO therapy, even though I think it's extremely exciting and promising in some of our fields, particularly ones where we haven't had a lot of effective therapy, the trouble with that is when we do run into side effects, they can last for a long period of time. They can be difficult to resolve. And we probably see a little bit higher percentage of patients that don't respond to IO therapies that do respond to TKI therapies. So when I'm looking at this mix, to me, the TKI therapies are still attractive for the patient that I feel like I really need this therapy to work, and I can't afford to have this disease go kind of unchecked for a long period of time. And so that the TKIs give me the opportunity to start there and to see how they respond, and to make sure I can get therapy on them and hold it and restart it if I need to. The IO therapies, I think, are great, particularly for our patients that have maybe a little bit more of that lower burden of disease, because if we do have to hold for a longer period of time, that disease burden can grow without necessarily causing a lot of symptoms. Or for people that, I can radiate some symptoms or do some other things in the context of that. So I kind of look at those factors as well. I think there's going to be an attractiveness to starting with IV IO therapy for a lot of folks long-term because of the long-term tolerance. But it's this sort of upfront beginning that I think is really key to really understanding, who can tolerate that and do well with that, and who maybe we need to hold that in reserve a little bit, start with a TKI. Recognize that for most of our kidney cancer patients, we're going to use both of these modalities, either in sequence or in combination eventually. One of the things that I think we've learned in kidney cancer over the last few years is that sequence may matter in this disease. So let me give you an example. Over the last 2 years, since 2015 now, we've had approved for renal cell carcinoma in the second-line space use of a single checkpoint, nivolumab, as well as a number of TKIs such as cabozantinib and axitinib. Now, what that's allowed us to do now is to be able to kind of shuffle a little bit in sequence. We've still, for the most part, started with VEGF TKIs like sunitinib and pazopanib, but when those patients progressed, we've been able to use a drug like nivolumab. The advantage of that has been to change mechanisms, to change side effect profiles, to allow patients to recover from some of the side effects they may have chronically experienced with TKIs, try a different modality, and really hit the tumor with a different strategy. Many times that has worked great, and we've seen responses, but there are also many patients that progress relatively rapidly coming off of VEGF TKI while on a checkpoint inhibitor like nivolumab. But what has been interesting is to see patients going back on TKIs like cabozantinib or axitinib and seeing the responses in that setting. And I think that does suggest that there is some benefit to changing these mechanisms. Some patients we may be able to treat concomitantly with these strategies. Other patients, it may be just as effective or maybe even better tolerated to take them kind of in sequence. And I think that's something we're going to continue to learn. I'm not sure we really know yet in kidney cancer what the best sequence is going to be for every patient.